Good afternoon. I'd like to welcome everybody to the Health and Adult Social Care panel. My name is Jo Lawson and I am the chair of the panel. We can just have a round of introductions from our other panel members and then our guests.
Thank you, Chair. Councillor Eric Firth, Dewsbury East.
Thank you. I'm Jane Ryler, Councillor for Home Valley South.
Hello, I'm Kim Taylor, Voluntary Co-optee.
Good afternoon, I'm Councillor Alison Munro, representing Almonbury Ward and Kirklees Council. Thank you.
Good afternoon, Chair. I'm Tim Bamford, representing Denbydale.
Afternoon, Vicky Dutchburn, Director of Operational Delivery and Performance for Kirklees ICB.
Afternoon, I'm Gary Boothby, Director of Finance at CHFT and also Kirklees Place Finance Lead for the NHS.
Hi, Cass Sims, Service Director for Adult Social Care Operations at Kirklees Council.
Afternoon, everybody. I'm Richard Cumbers. I'm Head of Service for Social Care Operations Independence. So nice to meet you.
Thank you. Do we have any apologies?
Apologies received from Helen Clay, Co-optee.
Thank you. And moving on to the minutes of the last meeting, can somebody move those as a correct record, or is there anything that you want to actually raise from the minutes?
Yeah, can I just say that I was present at the last meeting, but I was present as an observer.
Thank you, noted.
I'm happy to move those.
Okay. And do we have a seconder? Sorry, I kept looking at you as if to say, come on Eric, you could do that. Is moving on to declarations of interest. If I can just declare that I hold a bank contract with CHFT Trust.
None, Chair.
None for me, thank you.
None for me.
Agenda item 7, I don't have any questions, thank you.
Is admission of the public. Everything today will be discussed in public. Moving on to item number 5, are there any deputations or petitions?
None received, Chair.
And no public questions?
None received, Chair.
If we can then move on to item number 7, which is an update on the NHS 10-year plan.
Thank you, Chair. I can put the slides up if people would prefer, or the slides are in the information pack. Would you rather them be on the screen?
I personally would prefer them actually on the screen.
No
Thank
problem.
you.
I will join the meeting. Apologies. Everyone see that? Let's go on to, where is it? Okay, so this was an information for item, so I'm just going to briefly go through these slides for you. So this is around the NHS 10-year plan. Just a bit of background, the 10-year plan is part of the government's mission to build a health service fit for the future, as it says on there. And the first step in terms of that was to ask for an independent review of the current situation across the NHS, and that was conducted by Lord Darcy there, and there's a link to his findings. Just some of the kind of highlights, I guess, from his findings. He did find that public satisfaction around the NHS was at an all-time low at the moment, so that was, I think, one of the main reasons for the review. He identified issues around waiting lists, getting appointments with a GP, attendances at A&E, issues around cancer treatment, amongst others. He also identified that the budget wasn't possibly being spent in the correct places, so too much of the budget is being spent in hospitals and not enough in communities. He identified that there's probably not been enough capital investment over the last 10 to 15 years, and that the impact of the pandemic really does remain. So there's some more information on that link there. Following that, the government said that they wanted to produce a 10-year plan, which is what they are currently working on. There's really big changes in how health and care services need to work moving forward, and everybody has signed up to this approach. I think across the political spectrum, people agree that this is the right thing to do, across health and social care as well, academics, politicians, so this is an agreed approach. And the three big shifts up there, really, moving more care from hospitals to communities, so that sort of reflects what I just said there about too much of the money and resources is in hospitals and not enough in people's own communities. So things like delivering more tests, scans, etc. in community settings is much better than in those acute settings. The second big shift was to make better use of technology across health and social care. I think we've been talking about that for a long time. We know how much technology has advanced and improved over the last few years, and it continues to do so. So actually, how can we really tap into that and make sure that we're using it in the best way? And that includes things like our computer systems. We know even the simple things like GP computer system doesn't relate to health, the ones in the acute trusts, which don't relate to social care ones. So how can we make that better? Things like video appointments, we're still very highly reliant on letters and fax machines, etc. So really moving to a better technology. Including scanners, advanced robotics, so there's lots of opportunities in that as well. And then the third shift is that focus on prevention, not just treating illnesses, and I think we've been talking about that for a long time. You might hear that talked about in terms of a left shift, so let's move away from our acute provision and move downstream to look at how we can actually prevent illnesses in the first place. And I think everybody would agree that they are the best, they're the three shifts that we want to see across health and social care. So the next stage is it's not actually a consultation, it's a conversation. I think the government is saying that they really want input from individuals, from organisations, from staff who work across health and social care, as well as patients and people that use services. So they have set up a portal where people can put in their opinions. There's a series number of questions, and like I say, as individuals you can answer those. We will be making a submission in terms of health and adult social care across from Kirklees Council. That closes this Monday actually, so the link is in there, so anybody is welcome to put their views forward. And like I say, this is really approached to say they want to co-produce and co-design what this 10-year plan looks like. So got a bit of a blueprint about how we want to work and where the NHS needs to go, but actually how do we go about doing it? How do we prioritise that? They really want to hear from people. And then just some of the questions that are asked within that conversation are up on the screen there. So just your experiences in terms of a member of the public, workforce as well, any ideas for change, and any ideas that you think are barriers to access as well. So I would recommend that people do complete that on a personal basis. Like I say, we will be completing it as Kirklees Council as well for adult social care. So unless there's any questions, I think we can finish on that one.
Thank you. It was more of an actual comment. Is I read the overview letter that they actually did, and sometimes when you read these, you wonder what organisation they were actually looking at as somebody who was employed by the NHS, but I found that was actually quite brutally honest. It gave a really honest opinion from there. Regarding the shift to additional technologies, I would say that thanks to sort of COVID within ophthalmology, we have done quite a lot of stuff. We basically, he's like photographs of the backs of the eyes for us to examine, all sorts of things. We had a whole shift in our work load from there. So there are things that are moving forward, and is obviously what would be more ideal is to have some of the more expensive kit actually in, say, diagnostic units, so patients aren't having to travel up to either Calderdale or HRI to have all these tests done there. Has anybody else got any points or questions?
Yes, thank you. Yeah, I'm just interested in the changes that are going to come into place in terms of tests, scans, etc. Just as one example. I'm just wondering what sort of scans would be available then, say in GP surgery. Are we talking X-rays, ultrasound, something along those lines?
So I'll take that one if I can. So within the Kirklees footprint, we've got the Community Diagnostic Centre, the hub that we're working with the university on the university campus, and that's obviously our big priority that will kick in next year. And some of that is about big pieces of equipment, so MRI scanners, CT scanners, things that aren't suitable really for GP practices. But in addition to that, we are hoping to do more other diagnostics, phlebotomy, cardiology type scans, ECGs, things that can, I refer to them as a bit more plug-in and play machines rather than stuff that needs massive infrastructure. And that's all about health inequalities really, so hopefully giving better access to our population to services without them having to get themselves up to HRI or over to CRH. And it's a similar story on the services provided by Mid Yorks as well with their community diagnostic centre. But the Kirklees main offer will be through the university. And there is additional funding being made available for those all the time. So I was talking to colleagues before about additional capital that's being made available. So that remains the direction of travel. But that's more done in hubs than GP practices.
Thank you. Yeah.
Councillor Firth.
Just on the ECGs being done at doctor's surgeries, that's been done for years. And there's always been a plug-in, so your ECG can be sent online straight to a specialist, so we can have a look at it. So that's not new, is it?
No, I say I think different practices have got different offerings, and some of the work that we're doing with primary care is understanding and making sure there's an equal offer across the patch. So not all practices are offering those type of services, but that's where we'll work together. I say ECGs might be, there are other cardiology tests as well that involve more expensive equipment that from a critical mass point of view, you can justify having them done in a hub rather than a GP practice.
Councillor Firth? My apologies, I thought you wanted to come back. Is there any other questions the panel wants to raise? Okay, we'll move on then to item number 8, which is Health System Financial Overview.
Yeah, thank you. So say there is some information in the pack, and hopefully that's sufficient for partners around the table to view the information. I think I wanted to start by saying really, as the health and care partnership, what we do is we consider the finances of all system partners, not just NHS partners. So there are various forums where obviously we consider local authority finances within there, the hospices, Locala, and other partners that aren't necessarily strictly within the NHS. But I think we're conscious that obviously it has an impact on the patients that we serve. You know, most of the patients aren't too concerned about who it is that's providing that care, so we all need to deliver this collectively as a partnership. But in terms of overview and scrutiny and performance, the West Yorkshire integrated care system and the ICB, they focus, when they consider Kirklees, they focus on the financial performance of Kirklees ICB and also CHFT. So whilst we know that Mid Yorkshire Hospital supports a lot of our residents in the Dewsbury footprint, that tends to be covered by the Wakefield part of the ICB. So just moving on, overall, the partners for our patch had planned an overspend or a deficit for this year of £6.75 million. Now, this is different to local authority finances, but where you have to plan a balanced budget. But for partners within our footprint, we had planned a £6.75 million deficit. The original deficit plan was significantly higher than that, but for West Yorkshire there was a £50 million gap overall, and nationally a further £50 million was then provided to West Yorkshire, and of that £50 million, CHFT received 25 and Mid York's 14. So the real size of the underlying challenge for the two big providers within the footprint is actually £39 million worse. I think it's worth calling out as well that to deliver that £6.75 million overspend deficit, however you want to describe it, that assumes that as partners we're able to deliver £125 million worth of savings. So that is after we've delivered significant sums of savings, which for the acute providers is sort of 6.5%, and for the ICB around 3 or 4%. That's the kind of scale of efficiency that's required to deliver those plans. At month 7, we're behind those plans to the tune of £12 million. So at this stage, we'd plan to have a deficit of £5.86 million, and we're currently £18 million overspent, so a gap of £12 million after 7 months. The challenges that we've got that are driving that deficit are no different in our footprint to elsewhere across West Yorkshire or indeed nationally. So primary care budgets, significant pressures on continuing healthcare budgets. That's demand for activity, and their demand continues to grow. There's some significant pressures on pay awards for NHS partners in particular. So we're in a strange position in as much as nationally the pay awards are announced and theoretically they are funded. So in theory we receive some additional funds to cover those pay awards, but they're never quite sufficient when you model it through in terms of what it works out, and that's leaving all partners with a gap. And then there are also slippages on the efficiency programme. So where I talked about that £125 million, not all the £125 million is being delivered. It's not being fully identified across all partners. And then finally, the other big driver of the adverse variance that we've all got is to do with the volume of activity. Many of you will be aware of the increased demand on services, particularly at the front door through A&E departments, but also that leads to more patients in hospital beds, need to increase the number of beds we've got available and open, and that's causing significant pressures to the providers. That's driving a challenge year to date, and also into the next slide, which talks about our forecast. So in terms of forecasting for NHS partners, there's quite a process to go through before you're allowed to move away from your official forecast. So there are various steps and measures you need to go through, which includes board approval. At this stage, CHFT are suggesting that we hope to be able to deliver our plan for this financial year. However, Mid York's Teaching Trust are flagging now that their plan will not be deliverable. So their board are still working through the scale of the gap in terms of what that challenge looks like. But it's potentially up to about 15 million gap in terms of their challenge for this year. But importantly for colleagues around this table, Kirklees ICB and CHFT are currently planning to deliver the plans that we set at the start of the year. That's not going to be without challenges and not without risks, but we're currently forecasting to deliver. Those key risks There's significant volatility on drugs and prescribing and devices. Constantly there are new drugs that become available that we have to prescribe and make available for patients that are creating pressures within primary care budgets. There's still significant amount of activity that's going to the independent sector. So that's activity that goes direct from GPs to other providers to treat patients, and therefore trying to scale the size of that particular challenge isn't always easy. And then within the providers, I said that there are some other challenges around pay bandings for staff that most organisations are having to face up to, which is a national challenge, but up to each organisation to resolve. And as I say, significantly, winter and the winter challenges that we all face. So speaking on behalf of CHFT, I know that we are currently in all available beds. So we hadn't planned to be in all the beds, but we need to be because of the volume of activity that's coming through the front door. Year to date, we've seen an extra 7% attendances in terms of A&E departments, and we've seen 14% more non-elective activity. So those are patients that are admitted probably as a result of an attendance at A&E. That all requires us to increase our bed capacity, which is causing us challenges financially. Couple of other bits of information which hopefully is a bit more optimistic than the position I've just presented so far. In terms of capital, so for those of you that are not aware, we obviously, in addition to the £600 million that CHFT is spending on ongoing operational revenue costs, we plan to spend just short of £60 million on capital, which is doing some good things in terms of community diagnostic centres, supporting some of our reconfiguration plans, expansion of the pharmacy manufacturing unit at HRI, which is supporting 273 different NHS bodies. So there's some significant positive benefits in there as well. And finally, in terms of cash, obviously if you're spending more money than you receive, eventually you become short of cash. At this stage, we're not forecasting to require to borrow any more cash. It becomes a bit of a vicious circle, really, because when you need to borrow cash, you then get charged for borrowing that cash as well, so it becomes a bit of a spiral. Just for assurance, I've also put a slide in around benchmarking. So one of the things that we do as a healthcare partnership is try and understand whether the services that we are delivering, whether we're delivering them efficiently or not. The benchmarking and comparative data that I've got for West Yorkshire providers there shows that 100 becomes the mean, in the national mean, in terms of average price of delivering services, but actually based on the latest data, both CHFT and Mid Yorks are more efficient than most providers. So whilst we've got an overspend and we've both got underlying deficits, actually what we do is more efficient than the national average. There's also lots of other productivity data that we share, and we go through various scrutiny ourselves to make sure that providers are delivering things as efficiently as possible. And then finally, I think that the last thing I wanted to mention on that productivity and efficiency, partners across West Yorkshire, because of the financial position, commissioned a review from one of the big accountancy firms, PwC, to come in and review our processes, review our grips and controls, really try to identify any short-term opportunities to try and improve the financial position. Both Kirklees, ICB and CHFT can demonstrate that there are significant grips and controls in place. So that's things like vacancy control panels, discretionary non-pay panels, all those kinds of things to make sure that we're only really spending money where it's really essential. And then there are some other elements that, working as a partnership, hopefully we'll start to see some light on for next year. So we will be going into the next financial year with underlying financial deficits, significant sums at this stage. The things that we're doing as partners include some of the pathway redesign, which I think we might come on to elsewhere in the conversations really. And this is where, working as partners, we aim to do things slightly different rather than continuing to do things the way that we've always done them. So that was the overview of the overall financial position, but happy to take questions.
Thank you. Councillor Monroe?
Thank you very much, Chair. First of all, I'd like to know how are you going to reduce the adverse variant? You talk about the prescribing drugs and devices, the volatility. Presuming you mean the market for that. I don't know. And what's behind the increased activity? I've got 3 questions there. Thank you.
So in terms of, we're not in a position to say we will resolve that adverse variance. We're not in a position where we can say, well, we'll shut the doors. Patients still will attend A&E and we will still face those pressures. We're working with the national teams and let's be honest, this is a national picture, an overall challenge nationally about what the scale of that challenge looks like. I think what we are able to do is demonstrate to the national teams, which is part of the PwC review, that we're doing everything we can within our control. Probably leads on to your next question really about the general demand. You know, I think this isn't that we've got partners in the system that aren't doing their share. I think there's a general increase in demand throughout. So it's not, you know, in the past we might have said, oh, well, you know, GPs aren't doing this and they're sending more to the hospitals. Over. GPs are busier than they've ever been as well. Everybody's busier than they've ever been before. And it is a general challenge that I think we're all facing that we haven't got a solution to. And then that last point around prescribing, there are new drugs that are coming on board all the time. There's standardisation across West Yorkshire that's giving some challenges for Kirklees as we try and equalise the offer of what drugs are available, and it's that's giving us some of the challenges in terms of the prescribing pressures.
So can I just come back on sorry, so just to recap, so you it's not the volatility of the market, i.e. prices aren't increasing, or and the other thing is it could end up next year with an increased adverse variance in actual fact. Is that going to, could that continue to rise year on year?
So the task that we're being set is to try and reduce that overall deficit, but it's challenging. We will be going into the starting point for next year with an underlying deficit. So all partners are working on their financial plans for next year. We've done medium-term financial plans and they're going through individual partner boards at the moment. But certainly the providers, including South West Yorkshire Mental Health Trust, have got underlying deficits for next year. And some of that's driven by the 125 million efficiency savings that we had to identify. Some of those have been identified non-recurrently rather than recurrent savings. So for example, CHFT, we had a £32 million target to achieve. 14 million of that's been achieved non-recurrently. Well, that just kicks the can down the road till next year. You've then got to find that 14 and whatever the target was for next year. It's challenging.
Thank you, Chair. My question is around the A&E attendances, and I just wondered if there's any information about whether they are, I mean, I'm sure they are appropriate, but whether some of the attendances at A&E are more due to people not being able to access a GP or services in primary care. And also, as to, on a similar vein, is there any information to suggest that people are maybe presenting later? I think there was some after COVID that suggests that people are presenting later with symptoms and therefore more complex and require more, perhaps, inpatient care. I'm particularly interested in the A&E stats, really. Are they... it seems a bit unfair to say to people need to be there. I'm sure you wouldn't want to go unless you did, but... Is there any work done whether they could be cared for outside of A&E, maybe in walk-in or a GP practice?
So I think there's a mixed bag, if I'm honest, and this is where we work with partners like Vicky to try and understand, are there alternatives available? So should or could we be investing in extended opening hours for GP practices? What would that have the required benefit of in terms of reduced A&E attendances? There is some evidence to say that will have an impact, but equally there's evidence as well that the number of patients attending, generally their acuity is higher than it historically was.
Right.
So the number of admissions and things that result from an attendance remains high.
Okay. Thank you. I've got another question on a different track, just about the deficits. You mentioned pathway redesign, service redesign. Any kind of information on to what that might be? With Mid Yorks, it's really concerning, isn't it? I think their financial position is concerning to me. And I just wondered if, it may be too early to you may not have that information, but to me it's like, what are they going to stop doing? I presume there's going to be very strict vacancy controls that presumably would affect the waiting list management and elective surgery, and it almost feels like, well, worst case scenario, or when you talk about pathway redesign, what does that actually mean? Does that actually mean they're going to think about stopping some services potentially because they just can't afford to do them?
So at this moment in time, all organisations have had tight vacancy control processes in for the last 12, and including freezers for certain posts, often non-clinical posts. Each organisation has also put in quality impact assessment. So, you know, we've got to be careful when we're freezing posts, because if there's an adverse clinical impact as a result of that, then we've just got to be careful, haven't we, about how we do that. Seems unusual for me to say that as a finance director, but you know, we've got to be sensible about this, about the patients we're caring for. I think in terms of the pathway design process, that's about us trying to use the resources we've got as efficiently as possible. I think when we talk about elective, the way that elective activity gets funded in the current climate, you effectively get paid from the national team for any activity you do.
Right.
So nobody has slowed down any elective work.
Okay.
Because actually it's counterproductive to do so. These patients need that care, and actually you'd lose the income as well as the expenditure. So you may as well, if you're able to, continue to treat as many of those patients rather than storing up a problem later down the road. These patients will need that treatment at some point, and everybody's doing the best to try and reduce the time that patients are waiting for that treatment.
Okay, thank you.
Councillor Firth.
Thank you, Chair. You'll be pleased to know I have several questions. Can I ask first of all about reconfiguration? Liz and I sat on a panel with Mayfield councillors some years ago now on reconfiguration of our health services in Kirklees, called Wakefield. And we lost a lot of beds. You're saying now that all our beds are full. Are there any plans to open more beds? Are there any wards that you can actually open more beds into?
So in the reconfiguration plans, the overall bed base was going to remain the same. It would change between sites, but actually we would keep beds on the Huddersfield site available to flex into.
We're talking about the previous reconfiguration.
Yeah,
sorry.
yeah. But obviously in terms of reconfiguration, we're still not quite there yet.
So if you're full, where are you going to put people that are ill? How do you admit them if there's nowhere to put them? You said you're full, the hospitals are full.
And that's a challenge, and I think that's why we've got to look at pathway redesign, because there is no, you know, we've run out,
No
we
capacity.
will have run out of beds. And I say this isn't a problem that's unique to Huddersfield, CHFT, Mid York or West Yorkshire. This is a challenge everywhere.
God. Sorry, that was for me. Can I just touch on pharmacies now? We've been hearing and seeing lots of pharmacies closing, and yet not too long ago the government at the time, and I presume the government now, And we're asking people not to go to A&E, go use your pharmacy. They're clever people, they're used to medicines, and they can do some diagnosis and actually help keep people out of A&E. But yet, a lot of them are actually closing the doors or at risk of closing the doors. What are we going to do about that?
So the first thing I think is worth noting is that the hospitals are not responsible for the community pharmacists.
Yeah, I'm just looking at health pharmacy now.
Yeah, but I think what I need to do is make it explicit that that's not the responsibility of the hospitals. There is across West Yorkshire a whole programme of work looking at how we also support our community pharmacists, recognising that we have done the work around the 5 key, and it's only 5 key areas that they can do prescribing and diagnostics for, and it's some of the common infections like urinary tract infections, respiratory, and they can prescribe first level only antibiotics. So where that's in place, it's working, and we are measuring that. Those people wouldn't have gone to hospital. It's the impact on primary care that we're seeing from that. So if people turn up, and some of this is about our cultural shift as well. So I think somebody asked a question earlier about people turning up at the A&E departments. Would walk-in centres, etc. work better? We do have some, well, we have a walk-in centre on the Dewsbury site. Calderdale have changed their walk-in centre, which was out, I think, Todmorden, Sowerby Bridge End, and it's more of not a face-to-face, they do it by telephone contacts, because people choose not to use them unless they're on hospital sites. So we've got loads of evidence over the years that people look at where, I'm going to say, the lights are on, and that's where people turn up. So there is something about the cultural shift and what we can do. Getting the services closer to people's own homes. So those services that are already pharmacists that are within GP practice premises, they're doing better than some of our community ones. The big ones are doing better again, so your big ones like Boots, is it Welcome and things are doing well. It's the small independents that are really struggling, and it's not the impact of being able to do the diagnostics, it's wider prescribing, so it's the cost of some of the other drugs, they're doing that at a loss. But there is a big West Yorkshire programme looking at it to see where we can maximise that impact. The other thing that we're doing though is we're using pharmacists within GP practices in some of the different roles, so they're actually working alongside our GPs, our advanced nurse practitioners, to support the practices, I suppose, at source rather than necessarily from a pharmacy.
Thank you. And can I just ask more, bear with me, Chair, one more question. And we've touched on drugs. I take several, but that's for not this meeting. The availability of some drugs, well, it's simply not there. Is that due to our lack of manufacturing capability, or is it importing? Is it Brexit?
All of the above, I think. I think it's a combination of the lot, if I'm honest. I think the investment that I referenced around the pharmacy manufacturing unit is part of that, trying to increase the UK's resilience to produce some of those drugs. So 15 million investment in the pharmacy manufacturing unit at Acre Mill is to be able to support some of the things that we are struggling to import into the UK and meet patient needs in a timely manner.
Thank you. Are there any further questions? You can go after Jane.
Thank you. I'm just wondering if you could clarify something for me, and it may be just me that doesn't know this. But in terms of the ICB and the CHFT, then they get separate funding, because you said the ICB plan at a break-even position, whereas the CHFT are going to have a deficit. So how are those funds shared? If that makes sense.
So the ICB and CHFT are both statutory organisations in their own rights. The funding broadly comes into the West Yorkshire system via the ICB. The ICB then commission from mental health trust, acute providers, whoever they need to buy that care from. But they retain a budget themselves for primary care prescribing, for CHC, for GP drugs, those kind of services. So that's how the funding sort of flows into the system. Each organisation has a statutory duty to report its position. We are working in partnership, so I think we're very much, and part of my role is bringing partners together for us to try and work out where we can get the biggest bang for our buck, really, you know, and move it between partners if that's the right thing to do. But essentially, each organisation still has their own target to deliver against. Does that answer the question?
That does answer the question, yeah. But if I could just ask, so could the ICB move extra money into trusts?
It could, but and then I guess at this stage we're talking about moving the gap, moving the deficit. So we could argue that the commissioners, if they gave more money to the providers for the activity that's being delivered, that would sort the providers out, and therefore they wouldn't have a deficit. It just moved the hole somewhere else. And what we're collectively trying to do is say, well, regardless of where the hole sits, what are we going to do about it? I guess that's the true measure of success.
Okay, thank you.
Thank you. Councillor Bamford?
Yeah, hello. Most of my questions have been asked, but just one around the pharmacy manufacturing unit and the multi-storey car park. Do these just impact this financial year? And I would think the multi-storey car park produces some revenue. Does the pharmacy manufacturing unit produce any revenue, or is it just a saving? And you know, will any of this bleed into the next year? That's really what I want to know.
Yeah, so the multi-storey car park is obviously it's capital funding that we'll receive for the multi-storey car park at Caldale Royal Hospital, but it will obviously make a difference for residents of Kirklees that have been treated at CRH. The bulk of that expenditure will hit the next financial year, but you'll be aware the groundworks are taking place currently on the CRH site, so some of the car parks are shut, there's no staff parking available on site and so on. With regards to the pharmacy manufacturing unit, it does deliver a positive contribution for the trust, which means that we can then invest in more healthcare. So it delivers broadly about £2.5 million profit a year as an entity that we can then invest on delivering patient care.
Councillor Smage?
Thank you. I knew I couldn't observe without asking the question. Sorry. Councillor Smage, I'm Joint Chair of the Caldale and Kirklees Joint Health Scrutiny and Chair of the West Yorkshire Health Scrutiny. I just want to pick up on a point that you made, that the money for Mid-Yorkshire goes through the Wakefield ICB. So how does the Kirklees ICB Place Committee ensure that the services that we need in Kirklees are provided in Kirklees, especially when Mid-Yorkshire are in fact obviously have a larger deficit? Because Councillor Firth is right, we've been here before, and so I think it's important to find out how we ensure that we have services here in Kirklees rather than being a retraction into Wakefield's.
So just to clarify that then, so I think what I was trying to get at within there, because the boundaries of the different hospital organisations aren't coterminous with local authority boundaries, and to try and avoid duplication when it comes to the governance of monitoring performance, Mid-Yorkshire's performance is monitored in the same and faces the same overview and scrutiny under the Wakefield ICB banner, just as South West Yorkshire Mental Health is picked up as part of Calderdale, even though it serves the whole footprint across the patch. However, Mid-Yorks do have a key role still, just as Swift do, in the Health and Care Partnership Board, where we are discussing what healthcare provision we need, and the performance of Mid-Yorkshire Hospital is monitored in those forums, and say attended by the chief exec of Mid Yorks and so on. So it was just about how we financially report to save, well, for instance, save me going to 3 overview and scrutiny panels and the director of finance from Swift attending at least 4 or 5 kind of thing. That's the point I was trying to make. Sorry if that didn't come across.
I'm still confused. Vicky, can you help me out?
Yeah, so we as Kirklees, we commission from Mid York, so we attend contract monitoring, we do performance monitoring on the activity that is, I'm going to say, purchased for on behalf of our population, and we do that with Wakefield on the Mid York side, and we do it with Calderdale for CHFT. It's the West Yorkshire governance of understanding the deficit positions and monitoring that is taken by a place lead. So Kirklees lead the CHFT contract, Calderdale lead the Swift contract. We're still a partner to it and we still participate, and Wakefield lead the Mid Yorks contract. We're an active partner into those, but for reporting either back up to West Yorkshire or into scrutiny committees, it's been agreed that it'll be done by those places who lead the contracts. So what we do into our local place, and Gary's just mentioned our Health and Care Partnership Finance and Performance Committee, we have a Quality Committee, we have a Transformation Committee. At those committees, we do see the full Kirklees position of partners and our activity. So I'll give a really quick performance one. We understand in detail how many patients we've got waiting over 65 weeks, for example, and which site they're on, and we work with that partner to deal with it. So we don't have that currently with CHFT. All our waits are under 52 weeks. We have 4 patients, Kirklees residents, who are waiting over 65 weeks on the Mid Yorks, but we drill down into that level. So as an ICB, we have that oversight. It's just the reporting on the financials that goes back up to West Yorkshire through the lead commissioners.
Thank you. Does anybody online have any questions they wanted to ask? Nope. If I could just ask about the actual pay award, the Band 2 to Band 3 pay progression, is that across the board for every Band 2, or is it just in specific areas?
So it's in specific areas and it's a national challenge. So there's been a review that's been undertaken of Band 2s and been pushed for by the trade unions nationally. As there's been role creep, I guess, so a lot of the work that Band 2s do involves undertaking various diagnostics, various measures that were traditionally done by Band 3s. So Band 2s, are, from a nursing Band 2 point of view, are generally asking for regrades to Band 3s. Across West Yorkshire, 2 organisations have actually moved already, but there is a lack of clarity and a national steer about how long you go back for. Do you go back to when the claim first came in? Do you do it for all roles? And that, but so Mid Yorks have already made that move. CHFT haven't as of yet.
And when are CHFT likely to make that move?
So that is in discussions with the trade unions at this point in time. I know there's some further discussions taking place this week.
Thank you. Are there any further questions? Then we'll move on to agenda item 9, which is supporting hospital discharge.
Thank you. And again, I'll just pop this onto the screen, the presentation, so you can... Won't do that. So you can see it. So I think this follows on quite nicely from the conversation we've just had there, particularly around some of the issues around bed base and what's happening in the hospitals and how that can be supported most effectively. I will get this on slideshow this time. I wasn't able to do it last time. So Richard's going to take us through most of this, but hopefully we'll have an opportunity to have a good discussion afterwards. But we were asked really just to present what's happening in terms of how Kirklees Council are supporting with hospital discharge, which we know is a priority across the system. Richard.
Yeah, thanks, Kath. Hi, everybody. Thanks for having me. So basically, pulled together these slides. They probably don't flow quite the way we wanted them to, but if I'll talk through them. So basically what I want to do is kind of give a bit of a background about our teams in Kirklees, our social work, hospital teams, the discharge pathways that we follow to facilitate hospital discharges and some of the performance metrics around that, and then give a bit of a snapshot about some of the services that we've got in place to help with those discharge pathways. So we've just gone to the next slide, please.
Moving on my screen, but not on.
Okay, well, I've got a technical problem, so I'll keep talking. You've got it in front of you anyway. So basically, in terms of the volume, what colleagues have spoken about, obviously, we know the hospitals are really busy. A total of 18,689 hospital discharges were achieved between the 1st of Jan and the end of September this year. But what I want to flag is that of those, only quite a small proportion of those are social care interventions. So it's just worth kind of mentioning that we often get flagged in the press as kind of bed blocking, but in terms of actual proportions, we've got a relatively small proportion of interventions within the hospitals, but obviously it's an important one that we take very seriously. So in terms of the teams, we've got 2 assessment teams throughout Kirklees, one based at Dewsbury District Hospital serving Dewsbury and Wakefield and Mid Yorks, and the second is based at HRI Huddersfield, serving there and Calderdale. The teams that to date this year or to the end of October have completed a total of 1,528 care and support plans. So that's somebody who's been deemed as needing a social care intervention on the ward, and the teams have gone out and done a social care assessment with those individuals. Within our discharge approach in the hospitals, we take that multi-agency approach, so we have the integrated discharge meetings with therapists, nurses, online and on the wards as well, so we can get a kind of joined up approach to those discharges. We're measured on length of stay in terms of social care hospital teams, and I just want to kind of flag that. Coming to Kirklees, I started in Kirklees in August, and I used to work in another authority where we serve one trust, and I usually thought that all trusts had the same performance systems. That's not the case. So one of the difficulties that we've got in comparing performance across the footprint is that both trusts use separate performance management systems, but I believe that in the future that's going to be improved. So that's kind of linking back to some of the stuff that Kath was talking about before. So within your pack, I think it's slide 3 on my side, there's a kind of visual representation there, the home first discharge pathway that we take in Kirklees. So you can see we have that integrated transfer of care hub approach, and we always kind of push that home first approach as the first measure, that strength-based social care ethos that we've got within Kirklees. And then you can see across the slide, you've got pathways 0 right through to pathways 3. If you move onto slide 4, there's a little bit more detail in there. So even on pathway 0, which is where people tend to go home with no social care intervention, it's worth pointing out that even at that pathway, social care are involved in terms of commissioning the community transport offer and the Age UK offer, and also the care and support offer, which I'll talk about a bit later on. And then we move on to pathway 1, which is our home first approach, so reablement, so somebody who's well enough to go home but they need a little bit of help in that strength-based social care approach. Then we've got pathways 2A and 2B, which is the intermediate care and recovery bed offers, which I'm sure that you've heard about previously at Ings Grove and Moorlands Grange. So we've got 40 beds at each unit. Ings Grove is the intermediate care offer, where people can receive, they're well enough to get out of hospital, but we need a bit more help to kind of get them back on their feet. So they'll have a kind of short intervention at Ings Grove, or people who are a little bit better but not quite well enough to go home, they'll go to Moorlands in a recovery bed for kind of up to 4 to 6 weeks. And then pathway 3 is those individuals are deemed as needing kind of longer term care. If you move on to slide 5, which I imagine is quite difficult to read in your pack, so apologies for that, we can't get it on the screen. What I want to flag there is that, like I said, we really push that home first approach, and 94% of all discharges from the hospitals are on pathways 0 and pathways 1, so getting people home to where they want to be. And then there's a further 6% who unfortunately are on pathways 2 and 3 who need that a little bit more help. So in terms of the model that we're pushing in Kirklees and working with our partners with, that home first approach is working. It's not perfect, but the stats do support that measures in place and being activated. Slide 6, I just want to kind of touch on the some of the support services that we've got in place in terms of hospital discharge, supporting hospital discharge and hospital admission avoidance. So we've got the carers count, which is working with our informal carers, which there's a slide a bit further on there, Age UK. But some of the ones that I want to kind of draw your attention to, we've got the moving and handling team, which sits within our remit. So we're looking at how we can work with individuals to reduce the need for double up care, thus increasing capacity and making the services more accessible to more people. We've got the Scots team, which is our social care occupational therapist team, working closely with the with health colleagues and the assessment teams in the hospitals as well, looking at how we can take that strength-based approach again. And then we've got the Kirklees service, which is our integrated community equipment service, so getting people the right equipment to get them home safe in a timely fashion. And there's a slide at the end of the presentation about that. So just briefly again about the carers count service. So it's worth pointing out that we invest in unpaid carers across the piece in Kirklees, but this slide just kind of highlights a pilot or a scheme that's been launched in January this year, focused solely in the hospitals. So it's about the staff working with families, identifying those unpaid carers, flagging them to the carers count service, giving them lanyards so they're recognised as the carers, and signpost them to that support and that additional support that they may need themselves as carers. And today, I believe that there's been, well, up until the end of, I think, September this year, since January, there have been 231 carers identified just in the hospital settings themselves. So I think that's a real kind of success story. Obviously, it could be more, but there's 231 individuals there that have gone to hospital with a loved one, and they've also come out with some support themselves as that unpaid carer. And that, particularly if they're working on the pathway 0 and 1, getting people home first. The next slides, it's kind of a bit of a repetition, so apologies on that. So it's a bit more detail about the pathway 1 home first reablement. So I think it's just worth pointing out with these slides that this intervention is free of care package for up to 6 weeks for those identified, and the plan is that people will come out of hospital, have that help, and then after about 4 weeks they'll get a social care assessment if they still need one in their own home, looking at when they're better, not when they're at the strength again, so we can get the right care at the right time. Pathway 2, again, the intermediate care at Ings Grove. There's a lot of information on there, I'm not going to go through it, but I think it's just worth pointing out that the timeframes that we're looking at in terms of getting people from a hospital bed into Ings Grove, if that's identified as the correct pathway, is 48 hours from the referral to the placement. It doesn't always work, but we are working on that to kind of streamline that and get that better. And again, I'd kind of echo that for pathway 2B, the recovery beds. That's the model that we're working to with partners to get that offer in place within 48 hours. And again, that's for up to 4 to 6 weeks. In recovery beds, we can also support with the equipment orders. So if they are in that recovery bed, we can work with the individuals to get the equipments in place. And then the final slide in the deck is around the Kirklees, the Integrated Community Equipment Service. So what that slide shows you there is a number of pieces of equipment that have been ordered and delivered in each calendar month, going back to April 23. So if you look at October 2024, 500 pieces of equipment were ordered. The vast majority of those were orders from the acute sector, from urgent care, and all orders placed are delivered in the correct time frame. We've got 100% KPI in terms of delivery. So if you ordered it, if the nurse wants it same day, it'll get delivered same day, or next day, it'll get delivered next day. And that service is performing really well and helping with a lot of hospital avoidance and hospital discharges as well, and also cost avoidance as well, which is kind of well documented. So I don't know if you want to...
Yeah, just apologies again that the slides, we had a technical issue there, so you didn't get the slides on the screen, but they are all in your pack. So I think it's just overall to say that we've been working really closely with our ICB colleagues, with the acute trusts as well, and with Locala to really ensure that we have the services as streamlined as possible. Like Richard said, there's always areas for improvement. We absolutely know that, but all partners in the system are working to those end goals. Just worth touching on as well that the acute trusts do operate an OPAL level, so they can describe when there are particular pressures across the hospital, and we are able to respond to that appropriately as well. So I know at the moment CHFT are in OPAL 4. I know Councillor Lawson, you mentioned that specifically yesterday, just wanting to ask what the council response to that would be. What I would say is, really our response generally is working towards, getting as speedy discharge as possible. So we always kind of expecting to be at that OPAL 4 and putting in the support there. But when it does go to a level where we need to put additional support in, we bring our plans to the forth, which means, we can get some extra support from other teams in Kirklees Council to help, including our Community Plus teams to support with some of that Pathway Zero flow, and we would work really closely with our acute trusts when that happens. So we're happy to give some more information if there's any specific questions on that.
Thank you. One of the things that I actually noticed with the stakeholder briefing that we got regarding the OPAL 4 level was the bit with putting about the 20% of people who shouldn't be residing there. That was the same as last week. Then if you go back over to the summer months, it seems to be 17-18%. So it seems to be constant. I realise they're not the same 20% of people. Obviously, once you've discharged successfully one cohort, there are another one. Are there any plans to actually try and reduce that down?
That's absolutely ambition. That's what we're trying to do, and that's what all of the pathway redesign and all of the work that we're doing across the partners is trying to do. We really want to get that level down. I think sometimes Richard mentioned there about performance and getting the right data. So we've got to make sure that that's absolutely right. Sometimes somebody might be ready for a discharge on a Tuesday, and by Tuesday evening they're unwell again, and it starts again, and it's just remembering sometimes that the data isn't absolutely perfect, but we do know that that is absolutely our ambition to do that. I think it was interesting, sort of the current OPAL 4 situation has arisen because of a outbreak on some wards. So that meant that nobody really could get discharged from those wards. So that wasn't particularly anything that the system was doing wrong. It was a situation, and what we can do in situations like that is make sure we're prepared when that outbreak is finished and people are ready to be discharged, that we're ready and we're proactive in that support. So there's often different reasons as to why we'll say that the hospitals are under pressure, and we just need to be able to respond to that appropriately. But yeah, that's absolutely the ambition to bring that down.
Thank you. Is regarding the discharge performance, is obviously a successful discharge is when a patient doesn't get readmitted due to problems faced once back at home. What percentage of that, I think it was about 97% who are discharged onto Pathway 0 and 1 are actually readmitted?
The honest answer is I don't know. I can find out for you. I mean, there are readmissions. There definitely are. If you want a percentage, I'll have to go back and get that information. I haven't got it here, and I wouldn't want to say something that's not true. But yeah, you're right. People do get readmitted, unfortunately. People get poorly. But, I mean, Vicky, you probably know more than I do on that, so...
Yeah, so we do have the statistics. We record 2 indicators, but the main one that's looked at nationally is people readmitted within 30 days of discharge. So we'll be able to pull it. It's in all our performance reports. It is one of the ones that we collect.
Thank you. Another question that I had was regarding the trusted assessors. Can you just expand a little bit on that role?
Yeah, so the trust...
Oh, sorry, I thought...
Oh, no. So, yeah, we employ trusted assessors. Well, Kirker, the local Kirker organisation, I can't think what that stands for at the minute, but they employ trusted assessors on behalf of, in both trusts. So they basically assessors that work are based in the hospitals, but they do the assessments on behalf of the care home. So if someone's identified as being fit to go home, medically fit for discharge, rather than what's happened in the past is that a care home would then send one of their workers out to do their assessment of that individual. We've got people based in the hospital do that assessment on behalf of the care home and share that information back with them, and they can share that with multiple homes. So it saves. So in the past, potentially 3 homes could have come out and assessed one person. So now that trust assessor will do that assessment on behalf of the homes and share that information and hopefully facilitate a quicker discharge both for the individual and for the home as well. That's the role.
Thank you. And just one last question from me is patients that residents or patients that have been discharged onto the pathway 1 that need some kind of support which they would get in place for 4 weeks. If it was felt that it was needed for longer or maybe long term, when would they actually get an assessment to make sure that was still in place? It wasn't like 4 weeks was up and then they had to wait for an assessment.
Yeah, I think the great thing about the Pathway 1 reablement is that assessment can be happening while the reablement's taking place. So the period of 4 weeks is free for the person, 4 to 6 weeks, but you're doing that assessment, so absolutely at the end of that 4 to 6 weeks, if the person does require some ongoing care and support, it can start seamlessly afterwards. There shouldn't be a break. Sometimes if it's that you can't find somebody might need a domiciliary care provider, it might be that we ask reablement just to continue for a couple of days more, but actually we've got a really good provision around domiciliary care. So what we're saying is, if that reablement ends, domiciliary care can pick it up really quickly straight after. So, we want to get even slicker at it, but the reablement gives that opportunity for a Care Act assessment to be happening alongside, so that at the end the person can receive their long-term care and support.
Have the panel got any questions?
Thank you. Oh, we're all fighting. My question is around the no need to reside figures. And bearing in mind what you said, obviously there's an epidemic at the moment and the 20%, but going back to the summertime when it was 17 and 18%, and bearing in mind that you said 94% of the discharge are on pathway either 0 or 1, what is the reason for the 17, 18% around that figure still having no need to reside in hospital? Could that be because they're on the more complicated pathways, or is there something else that's we're not looking at?
So the no reason to reside is at the point somebody is deemed medically fit for discharge. Yeah. So there's a number of things happen. You might be told that you're medically fit to be discharged at 9 o'clock in the morning, because the other thing is all these are done on snapshots. So we see it in real time, but you're getting snapshots of data. So somebody's fit for discharge at 9 o'clock in the morning, you put in the package, whatever it is to get somebody out of hospital. So there's a number of things depending how quickly they're going to go home. Is the support already at home? Do we need to arrange transport? But then in and amongst that, they might need an extra blood test, or we find out that there's some results. So people can swap from being no reason to reside to needing to stay into hospital, but it's at that point that they are deemed medically fit. So everybody at some point will be on a no reason to reside, because you don't get told you're fit to go home when you walk out the door at that same time. Do you get what I mean?
Yeah, no, I understand. That's really helpful. So have you got any information on what the length of stay, once somebody's deemed no need to reside, what's the average length of stay then that they're in hospital where they don't need to?
I'm going to say it's about 4 days. Yeah, it's about so 4 and a half days is an average.
If you just potentially, and it's dependent on blood test,
it's dependent on them going home, that the family are okay with them to go home at that point, that we've got the transport in place. So and signing the papers, getting the medication. We're trying to bring that. We're trying to bring that forward. We is the royal we. So the acute trusts are doing lots of work on the pathways as well, about making sure that prescriptions are done as soon as possible, so that we're not backing up. Because the other thing for people as well is, I'm going to say, it's cut-off time. I call it a cut-off time. But it's about what we think is safe for people to be discharged. So you don't want to be discharging people at 8, 9 o'clock at night. Ideally, we want the beds. But if it's an elderly person going home to their own home on their own, it's making sure that they've got the heating on and things as well. So there's those things that play a part in doing this. But we've got a whole series of pathways. So the acute trusts themselves are doing lots of work about early recognition about when people should be fit for discharge, to make sure that all the blood tests are done and not going to be repeated, that the medication, we've got roving pharmacists, they're called out the Gary, roving pharmacists, Safari, that's it, they go around and do the ward rounds daily so that they can start getting the prescriptions and things ready so we don't end up with backlogs in the pharmacy department. We've got the ITOC hubs, which all the partners are part to help.
Because I know kind of there's a view, isn't there, the discharge should start when the patient's admitted.
Yeah,
and it's because
yeah. So and one of the things that we do
before planning.
And I think I'd say we're probably better than some other places at. Right. Is we don't. So if somebody goes in and they've already got their package in place, they've got a package. We don't actually stop those packages. We make sure we retain them, whether they're health or social care packages. Not indefinitely, don't get me wrong, if you're in for 12 months, it doesn't stay there for 12 months. But we do have a period of time where we say we will keep that package open with that domiciliary care provider or whoever, so it doesn't delay the discharge. It can be put straight back in place. And then we've got we've got flexibilities about if it's only a slight increase, it can be done immediately. It doesn't have to go through all the whole assessment process. We do that once somebody gets back home.
Okay, that's really useful. Thank you very much.
I think just to come in, you did ask, do people have a longer stay sometimes if they've got more complex needs on discharge? And I think the data would show that can be the case. So if somebody's needing to go into a nursing home or long-term care, people want to have a choice often as to where they're going to live full time, and so that can sometimes create a little bit more of a time lag as well.
Councillor Munro.
Thank you very much. I just wanted some information. So 18,689 hospital discharges have been activated across the 0 to 3 pathways, but we've not given any information. We don't know if that's good. We've nothing to compare it with. Is it working? Is it effective? My second question is, it doesn't tell us how long people are staying in hospital unnecessarily. For example, people who are on pathway 3, how long does it take to get that long-term package in place? I've heard of, people being in hospital for an awful long time before that package is actually arranged. Speaking from personal experience, in the case of really old people in the 90s, say, who've never been ill or ever been to the doctors, who present at A&E with an issue and then they're discharged home without any follow-up, without a follow-up appointment at the GP, and then have to be readmitted within the month because actually there's something seriously wrong with them. How, could that be looked at? Thank you.
Do you want me to take the last one first? Yeah. So any patient who's discharged from hospital, even if it's just that they've been in the ED department and gone straight home, the GPs are notified. So the GP is told why they were admitted and what medication or whatever they may have been given. Those patients are followed up. So within our primary care teams, we have, I'm just going to say, because I'm going to pick on Councillor first, there is differences across our practices. So one of the things they are working on, or we are working on, is our health inequalities. So some practices have care navigators, so they will pick up on a daily basis or the next day, depending how long it takes for the records to be updated, that an individual has been discharged. And then we'll look at who is the most appropriate person to follow that up. It can be done by a telephone contact, it can be done face-to-face, it could be done by our UCR team, our emergency response team, and people will go and make sure that there's a follow-up put in place. Doesn't mean necessarily that somebody would not be readmitted. And it doesn't mean that if there was something serious but it hadn't been identified and diagnosed, it still might get missed, and that's why people go. But for that immediate admission, we also look at the number of people who go in frequently. So not only have they been into A&E, if they're going to A&E and are not admitted to hospital, we look at how frequently some people present in A&E departments. So across the patch, we pick on people who've had 5 or more admissions. We've got to sort of set a boundary to be able to look at it. Then we look at what the community teams can offer, so the work that we do with our Locala service to support that. Our social prescribers can go in and try and target those people as well. So we have schemes in place. Some are run as our schemes as part of the NHS and what are routinely commissioned. Some are schemes that the individual practices do for their populations, and that's the bit that we're trying to do further work on to see can we get equity of that provision. Somebody asked earlier about weekends, other extra GP hours and things. What we have done is we've now got GPs open weekends, Saturdays, Sundays and bank holidays. So, but we've levelled that up, so some practices chose to do it themselves. What we've done is we've looked at where it's worked and we've levelled that up for times of immense pressure. So I'm going to talk winter. We have winter every year, don't we? Don't feel like we've come out of winter this year, but we've levelled that up, so we've put those in. We've put in extra on the PCN networks. We've put in what we call respiratory hubs. So one of the big things that we see, and current outbreaks are showing, is that they're usually respiratory conditions, or it was COVID. So we've put respiratory hubs in. So what the GPs are doing is diverting people away from the A&E departments into the specialist respiratory hubs and picking that up within our community teams, as opposed to people going in. They have a direct access both ways. So if somebody attends A&E, the A&E departments can contact the respiratory hubs. Equally, the respiratory hubs can contact the A&E departments. So if people are more acutely unwell and do need to be at ED, they can get them there, and it's the appropriate place to see them.
Could you just, so in relation to Pathway 3, so how long does it take to get those long-term packages in place? And are people staying in hospital bed, longer than they should be, basically? Or what's the procedure? What are you doing about those long-term packages? How long are they taking to put in place?
Myself and Richard will come in and answer this as a double act. In terms of the process, once it's identified that somebody does require a long-term package of care, the actual process of sourcing that care and support and giving options and choices to people, our targets would be across 5 days, but obviously that's if everything working absolutely perfectly, and people do want choice. And for people with specialist needs, for example, or complex needs, then sometimes it's more difficult to source those packages of care, but the brokerage process should be a turnaround within that 5 days. That's right, isn't it, Richard?
Yeah, that's right. And I think it's also with the complex placements, the residential manager is responsible for that care home. They've got a part to play in that as well. So they've got to obviously assess that individual to make sure that the home's right for them, but also they've got to think about the other residents as well. So they can't just accept everybody into a spare bed, because they've got to think about the other residents as well. So it's not always just, it's a real balancing act. So it's not always there's an empty bed there, they fit the criteria, therefore they can go in that bed. As a residential manager, they've got to really balance that approach, so that can also cause delays as well in the system, which is it's hard to report that, but I used to run the provider service in another authority, and that was often a real issue for us there. So I think it's something that's not easy to report, but it often does cause quite a lot of delays in terms of those more complex individuals. So.
Just on that, I was just going to say, just on that as well, West Yorkshire have got a consistent discharge protocol policy now about the lengths of stay that we want people to stay in hospital and how quickly we do it. And what I do need to say is that a lot of that work was based on the work that we'd already undertaken in Kirklees, because we were in a more favourable position than other areas. But within that, what it does do to try and help the system is look for places as well that are appropriate for the individual. Now, it doesn't always work, because people will say, I'm not moving and I'm staying put, but there are processes that can be enacted if we need to say, actually, you might not be able to get care home here, which is the one you really want, but we've got an appropriate one that can manage your needs and support you until a bed in X becomes available. But it's if I'm fair, it's about working in partnership. This is about working collaboratively. It's not easy for any part of the system. It's hard for the ward staff and nurses to be saying, well, you need to be discharged. It's hard for social care to say it. And it's trying, but we have a set of principles that we work towards as best we can.
I was just going to say, touching on your question about, well, is that good or not with the 94% and the 6%? It's difficult because some of the national targets actually they were only counting a certain amount of people and not others, but our target would be, we would want only 5% hopefully to go through the pathway 2 and 3. You've seen the pathway 3 numbers are coming down. We want that to come down even further. So about 4% of people at the moment are going through pathway 3. So that's going into that long-term nursing or residential care. We think actually if we can get more of those people going into our intermediate care services or our recovery bed services first, then they should be able to go home hopefully after that. So we want to just flip that pathway 2-3 percentage a bit. But I think in terms of the 0 and 1, we're meeting the targets that we would want to be meeting on those two.
Thank you. I'm just going to ask Stacey Appleyard, who's online, to speak.
Thank you, Chair. For those that don't know me, I'm Stacey Appleyard. I'm the Director of Health Watch Kirklees. It's not really a question, more of a comment. So Health Watch in Kirklees have spent the last 3 to 6 months working with discharge teams and partners in the system. We've spoken to people using pathways 0, 1 and 2 about their experiences, and patients say that the care they're currently receiving at home makes them feel more independent. People in pathway 2 spoke to us about how busy staff were. They spoke to us about how they would like more interaction with other patients if possible. They were also not sure about how long they were spending at the service before going home. People from ethnic minority communities were unsure if pathway 1 or 2 was free for a period of time. And they said that their families would appreciate more information being provided about this at hospitals. What I will say is all of our recommendations, the reports can be found on our website, but all of the recommendations that we made to the Ageing Well Board and to the Discharge Working Group in Kirklees and in Corderdale, they've received the recommendations and we're already seeing an impact and improvements based on that patient experience going back to them. So we've talked about the medications and how they might be delivered differently, and but yeah, the activities for group activities in pathways 2 already underway. So we're seeing improvements already. So as a Health Watch, we're really pleased with the way the patient experience has shaped these discharge pathways, and we hope to continue making changes in the future. Thank you.
Thank you, Stacey. It's good to actually hear that there is some positive feedback from the work that you've actually done. And I do know with regarding around ethnic minority groups, I was actually at the Pakistani Association in Thornton Lodge is a couple of weeks back, and it was good to actually see that work has actually been done, and maybe the take-up of the services will be better for the people from those communities as well. But thank you. Are there any further questions? Councillor.
Thank you, Chair. This all reads very well. It really does. You've got a plan, and if it all works, it's brilliant. But it doesn't always work, does it? I had a phone call earlier this month. It's more a question. It's easy a question. I'll get it one in and finish. I had a phone call this month. You discharged a chap in Ravensthorpe Sunday morning. He doesn't live with anyone. In fact, if it weren't for his neighbours, that chap might not have been here. Discharged into an empty, cold house, no food, no means of getting any. If it hadn't been for the chap opposite, that's an old friend, and his next door neighbour who brought him some food in, Philip sent 20 quid across to get a meal from a local cafe. Fortunately, he rung me, and I perhaps I should have rang 999 to get him back in, because he said he was falling all over the place. I got hold of the duty social worker, who said this chap was known to Kirklees, and believe it was her. Later that week, he was taken away Friday. I don't know where he's gone, by the way, but yeah, he's not living there anymore, because clearly he was still ill. But this doesn't, a lot of these things should apply to him, but it hasn't. We should have made sure that that house was, somebody were there, it was warm. I won't tell you what this chap said about the state of his house, because anyway, I won't mention his name, so we're okay. He says it's more like a cave. There's no carpets down, and it said, I'm paraphrasing now, it said it was a mess of the house. Shouldn't have been left there at all, but it was. Well, I'll pick it up with you after this meeting, and I'll give you his name and his address. But clearly, I know you can't get it right 100% of the time, but he was a 79-year-old man, obviously frail, and this shouldn't have happened, should it? Thank you, Chair.
Thank you. Councillor Ireland.
Thank you. Most of my questions have been answered by the rest of the team, but I just wanted to ask you about the carers count that you have on Pathway Zero, and what support those carers have. You were saying that you are investing more in those individuals.
Well, I mean, in terms of the support, it's a carer support service that's already in place, so it's offering them advice on you know, kind of, it might be around benefits, around getting extra help in, around help for themselves, helping to help themselves. The purpose of this pilot that's in the slides is focused specifically in hospitals, because what we're aware of is that a lot of people, the hardest thing with unpaid carers is identifying them, because a lot of them don't identify themselves. You don't realise you're a carer until somebody points it out to you, and that's not being patronising, that's just because they do such an amazing job. So the purpose of this is to help us identify those individuals who are doing that role, and getting the right support to them in the right time. I mean, it's been in place in Kirklees, as I understand, for a number of years, but the purpose is that we want to get it in the hospitals where people probably at the worst, they're at breaking point, and we want to, you know, stop them getting to breaking points. It's a lot of those individuals that help us achieve those discharge zeros, those discharge, you know, on the zeros and ones pathways, to stop people going into the care homes, and you know, they're the unsung heroes, they're the army. So that's the purpose of it. In terms of where they're located, you might know more than me, because I'm still pretty new to Kirklees, so I'm sorry I don't know the ins and outs of it as well as I should.
Yeah, we're just going to sort of follow on a little bit from Richard there. So that service specifically in the hospital is for somebody who might be the person that's providing that care at home, like Richard said, as an unpaid carer. So it's giving them some additional support and some advice. If they then required some ongoing, like they might need respite or they might need some additional support on top of that, they would then be referred back into the regular carers count service, if you like. So it's a bit of a two-phase thing. So this is a dedicated, focused piece of work. The carers count service covers the whole of Kirklees, so it doesn't matter where you live in Kirklees, you should be able to access the carers count service.
No, thank you. No, thank you very much. I mean, I recognise that. I mean, from my experience, how important carers are in keeping that whole system going. Yeah, thank you.
And I think one thing that carers have told us, you know, it's quite a stressful occurrence when you're taking the person you care for into hospital. Usually it's not an expected occurrence. It's been through A&E, get a shed load of information from a consultant or from a GP or from a nurse, so much information. It's just having that time to absorb it. What does that mean for the person I love, but also what does that mean for me as a carer? So it just gives that opportunity to have a good conversation with somebody who's got the time to have that, listen really and provide some advice and support.
Thank you.
Thank you. I was going to say around carers count, it is something that's an invaluable service for people, because as everybody else has said, is if there weren't people caring for their loved ones, this whole system would actually fall down on it, and it's actually being able to give them the support they need, the signposting to all the different things, to the benefits and everything. And I know that there's also been a big push on attendance allowance through community. Is it one community now? I always want to say community plus.
I was about to call it community plus, and just stop myself, but yes, integrate community services.
Yeah, it is, but there's all of those things that people don't quite realise when they end up in this sort of, sometimes through default, and they don't identify themselves rightly as carers, but they are actually doing everything there. And it's good to see that there are sort of all is trying to engage with as many people as possible. Are there any further questions?
Thank you. It's just about pathway to MB. Do we have enough beds in these? And if they're ever full, what happens to the patients that would be going there? Do they stay in hospital? And if they do, does that then feed into the no reason to reside figures?
It does. I think what we're seeing through our kind of, we called it demand and capacity modelling. So when we first started to, when we first set up these 40 beds across each, that's what we thought we would require. What we're finding is that the intermediate care beds are usually full or close to, but we've got to make sure we've got that turnaround. So if people can stay 4 to 6 weeks, we need to make sure we've got assessments so that people are coming out just as quickly as people are going in, which is a challenge. In terms of the recovery beds, there's 40 in there as well. What we're finding is they're not always full. So we do want to have a look at that and see whether we can be a bit more flexible. So if somebody's waiting for an intermediate care bed, but there's a bed free in the recovery beds, can we work a little bit differently? But I think the real challenge for us as a local authority is just to make sure that flow out of those services is steady, because otherwise we're just going to have a blockage there instead of at the hospital. So yeah, it is a challenge. We look at demand and capacity every year as part of the Better Care Fund modelling as well. And, you know, like I say, that was our modelling for last year, and we just keep that under constant review.
Are there any further questions? Councillor Firth.
It's not a question, Chair, but I'd just like to give a name check to Richard Parry, who won't be with us that much longer. And he helped me with a case. He's leaving. He's not passing away. He's leaving. But I'd like to thank him for what he's done for us over the last 10 years. He helped me only this week and helped me, NHS. A lady in my ward rang me about a dad. I won't mention any names. Who were actually bed blocking because they were a Kirklees and Wakefield, got the wires crossed, and he wanted somewhere to go quickly. Richard and his team sorted that out in 3 days. So I'd just like to thank Richard and his team on behalf of that family. He did a fine job. Thank you.
Thank you, Councillor Firth, for that positive news there. Going back to the Opal 4 situation there, is looking at sort of what we've been told, what Kirklees can actually do, and the situation with regards to the hospital. It's obviously down to probably norovirus or something similar there. What I would actually suggest that I would actually ask is if we could have, if it continues at 4, if we could just have sort of a weekly briefing on top of that.
Yeah, I mean, so one thing that we're going to step up in our team next week, we're going to have daily huddles in the discharge area of adult social care. So it's my assessment teams and the in-house provider. So we produce a lot of stats, we produce a lot of sit-rep reports, but we want to get that narrative right about that sits with that data. So we're starting that next week. We're hoping to embed that over the next few weeks going into the winter. So we should have that daily narrative. So if you do need any kind of updates, we should be able to provide that with you pretty quickly, and obviously Vicky and colleagues and on the silver calls as well, because one thing that I found coming in is that we get a lot of data, but it's quite hard to get that narrative that sits along it. It's like you say, we're like Kath explained before, hospital trust is an Opal 4, which is obviously terrible, but we're doing all that we can as an assessment team at this point in time, but we will build So I'd be building that narrative up and happy to share that as and when required.
That's good to hear. If obviously if it stays at the next reporting, which is going to be obviously about this time next week as a 4, it would be good if you could either contact myself or Nicola, is just by email, just to let us know that what's actually happening there.
I think it's worth saying about the Opal rating, because there's some new scores coming in as well for our community services that are all going to be starting as well. It's very rare that we actually hit an Opal 4. We go in and out, so there might be a slot in a day, so you might have an half-hour period or an hour period. It's rare that we stay in Opal 4 for any prolonged period of time. What we can do, and I will do, is I'll work with Richard, because we get 4 reports a day on the Opal status, not only of our immediate hospitals, but those hospitals across West Yorkshire. So, but that's done on if I say consistency, so it's where they're at over a time period, rather than at 10:15 they might have gone into Opal 4, but by 10:30 they've come back out. And again, I think it's worth noting that some elements of services can tip into Opal 4, not the whole hospital trust. So I think it's fair to say we had an issue with paediatrics, and we've had that on both sides of the patch, because RSV, respiratory whatever virus, has shot up, and we're using a lot of beds for that. Again, it's just starting to come down. And then it feeds into the point that was made earlier on today. It's us monitoring that. So what we're doing is, because we know there's a norovirus outbreak and there's been the RSV, and we know some wards have been shut, which is what tipped us into Opal 4, what we're already doing, and we sat on a call yesterday, myself and Richard, is we're planning 10 days hence, because we know that those people will start hitting to come out of hospital at that point. So we're expecting to see a peak in a pressure on the numbers that need to come out at that point. So it's what can we forward plan.
Thank you, that's good to hear. Can I also thank everybody for their reports and answering all our questions? Thank you.
Thank you. Thank you. Thank you.
We'll just move on to the work plan, and that's the final item on there. We may need to add on the paediatric audiology service. Sorry, we may need to add on the paediatric audiology service, but I'm having a briefing around that is in about a week's time, because when they've done work on a national basis, they've realised that certain trusts aren't sort of identifying, but it's obviously now seeing what work is actually in place from there. So that will be there. As in for is, don't forget, we've got an informal briefing on children's vaccinations on the 16th of January, and then there is the actual meeting on the 22nd of January, which is going through the access to dental. Children's Scrutiny panel will be also joining us at that meeting, all hygiene, and then we should hopefully have the CQC coming back and maybe answering a few more of our questions that they couldn't done last time. Yep, it is access to dentistry. That is the 22nd of January.